The title of my talk will be What Illnesses Should Concern You When Using Injectables. The talk is actually not very long. The reason is that there's very few illnesses that you have to be concerned about, fortunately. When you look at the FDA website regarding neurotoxins, this is the following list that really comes up into play when you do an internet search or any kind of just generalized search. Known hypersensitivity to neurotoxin or albumin. Many of the neurotoxins, especially Botox, contain certain proteins, and if you have a known hypersensitivity to those proteins, then unfortunately you might have a sensitivity to that formulation. Other neurotoxins such as Dysport, which are less protein bound, those risks theoretically decrease, though I've never seen any papers sort of comparing the allergenicity profile for both neurotoxins. As Dr. Nestor was pointing out, any infection at the injection site should be an immediate contraindication for the use of neurotoxins, whether it be a bacterial infection such as staph, or even a viral infection such as a herpetic infection. The use of Hibiclens is always recommended to my patients, even though you do have to be careful around certain sites like the eyes because you can get corneal irritation, because what it does do is it does inactivate, particularly with respect to gram-positive and gram-negative bacteria, those organisms, so it's actually safe to use. You don't want to inadvertently inoculate the patient when you're injecting with them. The next syndromes are really syndromes that are very rare, and when they come in, this is why it is very important to look. I actually had a patient who one time came in for Botox, and I just didn't tell me up front, but I actually saw it on their past medical history. They had one of these syndromes, and I was like, yeah, I think you failed to mention this to me. So it's very important. So the next slide shows exactly what the actual mechanism for Botox is. And as you can actually see here, right here, SNAP25 is a docking protein, and this docking protein enables the release of acetylcholine from a compartment in the cell called an endocytic vesicle, and it prevents the release of acetylcholine at the neuromuscular junction. That's how Botox works. And most of the botulinum toxins that are approved in the US, they all cleave SNAP25, which is that docking protein. Now, if you have an underlying illness where there is already some kind of disorder at the neuromuscular junction, then you're just actually compounding the problem. So that's why you have to be careful of that particular illness when injecting botulinum toxin. So myasthenia gravis is an autoimmune condition. It's characterized by the development of antibodies to the acetylcholine receptor. It results in the reduced neuromuscular transmission at the neuromuscular synapse due to, again, to antibodies to the receptor for acetylcholine at the junction. One of the things that you have to know about with myasthenia gravis, it's much more common in patients with an underlying condition known as thymoma, which is a sort of a large lesion that can develop in the sternal area, and it's often associated with the development of this condition. Characteristics of this disease include diplopia, ptosis, dysarthria, and weakness. And the treatment is actually to use medicines that increase the concentration of acetylcholine at the neuromuscular junction. In this particular case, anticholinesterases. Once acetylcholine is released at this junction, there's a series of enzymes that come into play that actually break it down so to stop the transmission of the nerve impulse. You can increase the concentration of acetylcholine here by actually decreasing the amount of enzyme to break it down. But again, in patients with underlying myasthenia gravis, if you try to inject them with neurotoxin, this can be a bad thing because you're just going to aggravate an underlying condition, particularly a feature such as diplopia when you're injecting around the eyes. LambertEaton Syndrome is another form of myasthenia gravis in the sense that you also develop antibodies to voltage-gated calcium channels. It results in reduced acetylcholine release at the neuromuscular junction. It's often associated with lung cancer. It's considered what they call a paraneoplastic phenomenon. So patients with lung cancer develop these antibodies to the acetylcholine receptors at the neuromuscular junction. The symptoms include proximal muscle weakness, autonomic dysfunction, and again, the treatment, as with myasthenia gravis, is the use of acetylcholinesterases that sort of increase the concentration. But you have to be careful, again, in injecting these patients. There's another disease known as amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. It's characterized by progressive neurodegeneration due to motor neuron death. 95% of cases are actually idiopathic. Symptoms include muscular atrophy, weakness, difficulty breathing, and swallowing. The treatments are shown here, but again, in a patient with these sort of underlying condition. I doubt many of you would see this in practice, but it's very important. Cosmetic enhancement for most of these patients would be the last thing on their mind. There's also, it's interesting in terms of neurotoxin interactions. There are a lot of medications that we sort of forget to screen our patients for that when you use neurotoxin can interact with them and actually make the toxic effects of the medication even worse. So the following medications decrease neuromuscular transmission, and the addition of botulinum toxin can actually make it worse. Those include aminoglycosides, such as amikacin, gentamicin, and streptomycin, patients on penicillamine, patients on quinine, chloroquine, and hydroxychloroquine. Those are usually anti-malarial agents, but they're often used for the treatment of patients with things such as cutaneous lupus. So a lot of dermatologic patients might have those. Calcium channel blockers, verapamil, amlodipine, nifedipine. These are very common blood pressure medications, and they can actually make the effects. Now, some of you might say, oh, actually, it'll prolong the use of the Botox. Yes, in one sense, it might actually potentiate the effects of your neurotoxin. But at the same time, if you use very high doses, especially around areas like the neck, for example, as Dr. Nestor was saying, if you exceed 60 units in the neck, you might actually create an inadvertent dysphagia. Other things that can actually, and I did not know this, aspirin and warfarin actually have qualities to them that also decrease neuromuscular transmission. And of course, anticholinergics such as oxybutynin and scopolamine. Oxybutynin is usually used, it's also known as Detrol, is used for the treatment of bladder incontinence. Now, the use of neurotoxins in pregnancy and lactation. That in itself is sort of a whole gamut. The FDA currently classifies botulinum toxin as category C, so being shown unsafe when tested in laboratory animals. Small quantities are unlikely to affect the fetus, but the risk is actually largely unknown. There have been no reports in the literature of fetal abnormalities among pregnant women treated, and it's unlikely to be passed through breast milk, but the risk is really unknown. No one's ever really done a study. They recommend delaying treatment until after delivery and nursing. I actually had a patient once who said that, who insisted, she comes in regularly for Botox, and she said that she insisted, and she was pregnant, that I give her neurotoxin injection. I said, well, you're pregnant, I really can't do that. And she goes, well, I really want it. I'm not going to look like this way through my entire pregnancy. So her mother-in-law was there, and she goes, well, it doesn't really matter because you're having a girl, so go ahead and get it, but if it were a boy, I would say no. I do not know why she said that. But just as a general survey, how many of you would inject a pregnant patient with neurotoxin? I'm just curious. Would inject a pregnant woman with neurotoxin? No one here. What about a nursing mother? Exactly. I mean, if you ask most people say no, though if you really look on the internet, on particularly a website known as realself.com, believe it or not, there's many an eminent provider out there who would say that, oh, I think it's okay in nursing, but who wants to be the first one to discover a side effect? So I think in general, it's just safer to not tempt the fates. Now, other than those diseases, those are the main ones that you have to worry about when injecting neurotoxin. Now let's go on to dermal fillers. Again, if you look at the FDA warnings, the FDA labels, and the package inserts, these are really the main medical conditions that you have to worry about when injecting filler. First of all, hypersensitivity to the filler substance. Unfortunately, many of us don't know if the patient's going to have a filler. You can have sometimes a first-time patient who becomes hypersensitive and you only know after the first injection. However, if you do screen them, you ask them, have you had this before? Have you had an allergic reaction? I think everyone should be asked that because Once it takes one exposure, the second exposure will be even that much worse because of sensitization. Hypersensitivity to lidocaine, which Dr. Weibel talked about in her talk, especially because a lot of the new fillers are pre-mixed with lidocaine. Any hypersensitivity to lidocaine should automatically sort of tell you not to use the fillers that have lidocaine mixed into them. But also, as Dr. Weibel was also talking about, many of the allergies to lidocaine aren't to lidocaine itself, because lidocaine is not a protein. It's actually to the preservatives within lidocaine. So just because they say, oh, I'm allergic to lidocaine, it's probably more likely some kind of stabilizing substance or preservative within it. Other possibilities are hypersensitivity to bee venom. Now, hypersensitive to bee venom is very interesting. That in itself is really more of a risk with the use of hyaluronidase, which is the enzyme used to dissolve hyaluronic acid. I've had a couple of patients who come in. If you look at the actual contents of bee venom, hyaluronidase is one of the main factors in bee venom. Hyaluronic acid is not necessarily. So even though it says hypersensitivity to bee venom, and I've actually injected a patient inadvertently not knowing that they had a history of bee venom allergy without any problem. So I do think this is one thing that deserves sort of greater attention. There's not much written in the literature about it. Any history of severe allergy or anaphylaxis to anything should also be considered, especially if you're using any kind of topical or if you're using latex gloves, for example. Those are things that you should be wary about when injecting fillers. Active infection near the injection site. As Dr. Nestor was talking about, the creation of biofilms, especially with the larger fillers, is something that has been recently talked about a lot in the literature. And all you need to do is have a filler mix with some kind of bacteria and then have it implanted. It creates this biofilm that's very difficult to treat with antibiotics because the drug can actually not get there. So that's very important. The final part of my talk is I just want to concentrate is on bleeding disorders themselves. There are certain bleeding disorders that you need to be wary when you're injecting fillers. I'm going to go through this. This is just talking about different anesthetics. So in case you have a patient who is allergic to lidocaine, you can use an anesthetic that is an ester. Esters include things like procaine, tetracaine, carbocaine. They typically all have one I in their names, but they do cross-react with certain medications that you do have to be careful about: sulfas, thiazides, PABA, and PPD. So if you have a patient who's allergic to lidocaine, so you use a lidocaine-free filler, but they still want numbing and you want to mix it, then you could use one of the esters: procaine, carbocaine, tetracaine. The only problem is you have to be careful because you have to make sure the patients do not have a pre-existing allergy to sulfathiazides, PABA, PPD, which is a paraphenylene diamine or hair dye, because if they do, they will be allergic to the use of that agent as well. In terms of bleeding disorders that we need to be concerned about, first of all, platelet disorders and vascular disorders. There's two types of bleeding disorders, one due to the platelets and one due to the actual clotting factor themselves. So there are a variety of platelet disorders, both acquired and inherited, that you need to be careful about. There's also a variety of coagulation disorders you have to be careful about. So first of all, what are some of the acquired diseases that you need to be watchful over in assessing your patients when in their sort of prehistory? Vitamin K deficiency. There are some patients who have vitamin K deficiency. The use of Coumadin. Any kind of underlying liver disease, particularly to hepatitis B or C. Patients with DIC. It's very unlikely that you're going to see a patient with DIC trying to get filler in your office, unless you're trying to do some last-minute salvage procedure in the hospital and they're septic. Antibodies against factor VIII. Any patient that recently underwent a massive transfusion of any sort. But I think most of us really have to concentrate on medications. So here are some of the medications that we commonly encounter that are prescribed by family practice physicians that you should be wary about when injecting fillers because they can produce bleeding. So obviously there's aspirin, there's Plavix, there's ibuprofen, certain herbal supplements. I always ask my patients, especially when I'm doing surgery, if they're on vitamin E, fish oil, particularly omega-3 fish oils, garlic supplements, and ginkgo biloba supplements. Other medications, Coumadin, Lovenox, Perdaxa, Effient, Xarelto, and now there's another one called Eliquis. So you should be careful when you're talking to your patients that they're not on these medications. Now, there are some patients who have what they call thrombocytopenia. Thrombocytopenia, for many of you who remember, is just due to low platelets. In the majority of cases, thrombocytopenia on a lab is just due to a false reading. So if you ever have a patient who comes in, says, I have low platelets according to my doctor, they'll say, well, have them, check it again. But there are some conditions where you really do have a failure to produce platelets. Typically, those can be acquired or inherited. So certain medications, alcohol, can actually reduce someone. So if you have someone that you suspect of excessive alcohol consumption, and I've had patients like that, very often they bleed very easily. Then there's inherited conditions. There's something known as TAR syndrome or Wiskott-Aldrich syndrome. Very rare. I'd be surprised if any. I think I've seen one in my throughout my entire residency. But these are syndromes that are associated with an inherited low platelet level. And then there are immune conditions, immune thrombocytopenia, people who actually, their body's producing antibodies, and due to these antibodies, all the platelets are getting consumed in the spleen. These are the other possibilities. There's also TTP, and of course, as I said, DIC. There's also disorders where the platelet numbers are normal, but you actually have disorders of platelet function. And again, I'm not going to go into the intricacies of what's wrong with these in these patients, but you should just know if you're looking at your intake history, they have a history of von Willebrand's disease, Glanzmann's thrombocythemia, Bernard-Soulier disease, storage pool disease. Any kind of this list on your report, you should be careful because these patients can bleed on you, and you won't find out until they come back an hour later with a large hematoma. And again, there are some acquired disorders of platelet function where the numbers are normal, but the function is actually inhibited. And those include certain medications like aspirin and ibuprofen, patients with myelodysplastic syndromes, patients with multiple myeloma, and patients who are kidney failure patients and who have uremia. Other inherited coagulation disorders. Now, coagulation disorders are different. They don't involve the platelets. They involve actually the factors involved in clotting. Those are known as the hemophilias. And then there's another disease also known as von Willebrand's disease. Hemophilias are really, the diagnoses are made based on the factor level and the history. And replacing these factors is the key thing. But you also have to remember that every time you give a transfusion, or these patients are given more transfusions of factor, they actually end up developing more antibodies. So if they have a history of hemophilia with a lot of transfusions, they might even be harder to treat because not only will you get bleeding, you might not be able to reverse the bleeding. So that's another thing to sort of be concerned about. Other inherited coagulation disorders are factor VIII deficiency, which can be severe in less than 1% of patients, moderate in 1 to 5% of patients, or mild or in 5 to 20% of patients. After repeated doses of factor VIII, patients can develop an antibody against the factor. So as I said, those are the types of patients you really want to sort of stay away from, because if they have a history of any kind of coagulative disorder, they've had multiple transfusions, they're at high risk for bleeding and at high risk for being sort of having a difficulty with future management. Other inherited factor deficiencies, factor XI deficiencies, factor 13 deficiency, factor 7, and factor 10 deficiencies. Again, usually your patients are pretty good at telling you about that, as long as on your form you have a very good intake that says, do you have any history of problems with bleeding? Remember that bleeding can occur because of injury with no bleeding diathesis. And what does this mean? Just because your patient's bleeding and developing a bruise doesn't mean, it's the patient's fault. They have a bleeding diathesis. You could actually have hit a vessel. So always remember that. Don't always the first thing you should always think is there a vessel there? Should I treat that first? And then if you can't, then think of whether there's actually an emergency related to an underlying condition. But the best way to know is just to ask the patient, do they have heavy menorrhagia? Do they have difficulty with bleeding during dental procedures? Those are one of the sort of common questions that I always ask my filler patients, because that's probably the best way for screening for inherited problems with bleeding. Again, managing these emergencies, you don't have to manage them, refer them in a lot of times. This is with patients with inherited factor deficiencies or platelet deficiencies. Be sure you have a proper diagnosis, and be sure that you're nearby an institution that has a capacity to deal with this, because yes, there are patients who will slip through the cracks. You will treat them, and then you'll find out that they have a bleeding diathesis. Make sure that you have a good system to refer to if this ever comes up. As I said, again, with no history of bleeding in the past or no history at all, if you have a patient that's been having like this prolonged hematoma, check a PT, PTT, check platelet levels, just as a screening mechanism to see if this is maybe one of the reasons why your patient doesn't seem to be resolving their hematoma. Now, the final part of my talk, I just want to talk about some easy treatments for bruising. First of all, when you're injecting fillers, as soon as you see and you pull that needle or cannula out and you see bleeding, the best way to stop bleeding is your finger or direct pressure with a Q-tip. Direct pressure is immediate, right after injection is the best way to stop. I actually did a general surgery residency for 3 years. If you have bleeding or you nick an aorta, the best thing is put your finger right on that point, right. And we're not dealing with vessels that big on the face, thank God, but that's the best thing, because it really will reduce the amount of postoperative bruising that you have if you immediately put pressure once you withdraw that cannula or that needle. Obviously, ice, head elevation, because it decreases the amount of blood flow to the head and brings it down to the heart, so it'll decrease the amount of venous distension you have. And of course, there's over-the-counter remedies. I love bromelain. Bromelain is a substance that you can either tell patients, you can take pineapple juice because it's found in high concentrations in bromelain. You do have to be careful when you're talking about bromelain to your patients with diabetes, because it does contain bromelain in pineapple juice. There is a lot of sugar. So you can also recommend topical bromelain tablets from like a holistic pharmacy. I like arnica as well. I personally feel, and again, I don't have any evidence for this, that arnica helps more with swelling rather than bruising, but I always recommend it to my patients if I'm suspecting that there's going to be some kind of bruising event. Now, there's a lot of topical vitamin K formulations that are excellent. Vitamin K is a natural clotting factor. So very often what I'll do is, if I think they're going to bruise right after injection, I have them use this right away after the procedure. And Mirvaso, topical brominidine, has also been reported. Mirvaso, as you know, is a topical alpha agonist. And what it does is it actually constricts the blood vessel. So immediately after bleeding, if you put the Mirvaso on there, it can constrict the blood vessel and stop the accumulation of bruising in your patient. There's also been some reports about the use of pulse dye laser for post-procedure bruising. Superficial bruises are typically, we recommend treating 48 to 72 hours after the procedure. For deep bruises where there's a lot of overlying swelling, you might have to wait 5 to 10 days after, because even if you use the pulse dye laser, the wavelength isn't long enough to actually penetrate where the blood is. Unless you use a longer wavelength laser, such as Alexandrite 755 or 1064, which doesn't necessarily target blood as well, but it may be useful in those patients who have a lot of swelling and you want to treat them faster. It's been shown that there's been significant amount improving, though there was a recent article in the 2013 issue of Dermatologic Surgery which compared laser to others therapies, such as the use of 3% hydrogen peroxide, 3%, cold compresses, and over-the-counter bruise serums. They actually found no difference. This is a paper that I often use and cite. It's a very sort of simple case report that was published by Dr. Geronimus's group. And these settings are the ones that they often use with bruising. It's a 10 millimeter spot, 595 laser, 7.5 joules per centimeter squared, and 6 milliseconds. Some of you might think this is counterintuitive. You're like, well, how does this work? This is blood outside of vessels. As you can see in this particular picture, there's two bruises, one on the right and one on the left. And the one on the left was treated with laser while the one on the right wasn't. And you can see how much quicker the bruise actually resolves. And I've done this. I've had some patients where I've injected with filler. They're like, I cannot be bruised. I have this event. And I said, okay, then come in, we'll pulse dye you in like 48 to 72 hours, and it works very well. So I do recommend that. So that's it for that lecture. I'll take any questions before I move on to my next lecture. Yes?
If
Mm-hmm.
Everybody's going to swell.
Right.
When they get a big sting. And then they come in and they say, I'm allergic to these things, but I don't consider that a true allergy.
Exactly. A true emergency or anaphylactic reaction, which is caused by the massive release of histamine, is usually characterized by your throat actually closing, difficulty breathing. It's not just a wheel and flare response. So be very specific, and a drop in blood pressure due to the massive vasodilatation that happens. That's why I always ask, well, just because you had swelling doesn't necessarily mean, I was like, tell me more sort of succinctly what happened. Did you actually pass out? Did your blood pressure drop? Did you have any, did your tongue swell? And did your larynx close? Thank you.
Yeah, I just had a question about arnica and people with a history of strokes or an MI. Should we be telling them, go home, take your arnica, or is there a contraindication with clotting and swelling?
It's interesting with arnica. I've heard sort of different things, and same with bromelain. I don't know if there's been some large studies saying that arnica is actually sort of dangerous, but I've also not seen of any large studies where arnica is actually the cure-all for bruising and any kind of edema. One of the things that I would say is that bromelain you actually have to be even more careful about. There have been some case reports with bromelain that, because what bromelain is it's a fibrinolytic. It actually causes the bruise to dissolve. And there are some people who think by activating that same system, it actually causes more bleeding. And there have been some patients who've taken sort of these large amounts of these bromelain supplements that they end up getting large GI bleeds. So generally, I think the arnica that I prescribe is always topical. So I usually give topical arnica, and then I tell patients to drink pineapple juice because the bromelain in pineapple juice is very low. Though again, I tell my diabetic patients they need to watch their sugar. So again, pineapple juice and topical arnica. You could take the oral arnica. Again, theoretically there could be, maybe a risk with arnica with some kind of, bleeding or a stroke event, but I've never seen any kind of literature supporting that.
So why do you use topical versus oral, just for that reason?
Just for that reason, just to sort of stay in my safety zone.
Okay.
Yeah.
I have a question about major autoimmune illnesses and subsequent immunosuppressants with dermal fillers and laser-based therapies.
So the use of immunosuppressive agents in patients with autoimmune disease and the use of fillers?
Yes. Do you have any? Because I know I think it's in one of the Allergan.
Right. That is definitely something that
caution.
they do talk about that, about being careful, that patients who are naturally immunosuppressed, I kind of went through that slide quickly, but they're patients with HIV, patients with inherited immunodeficiency, and the two most common are selective IgA deficiency and common variable immune system, and then organ transplant patients or patients with, say, very severe systemic lupus on severe immunosuppressive agents. They'd say, well, you need to be careful. I have actually injected patients. We have, at Albert Einstein, we have a lot of patients who are on the organ transplant system that have come in, and I have injected fillers. And I think as long as you adhere to sterile technique, that it should be fine. I haven't noticed any difference, and I haven't encountered any problems. But again, if you had to go by FDA labeling and you want to be on the safe side, then don't.
And is the same true for somebody with rheumatoid arthritis on low-dose methotrexate?
Yeah, again, I have it. I have a lot of patients with psoriasis who've come in for filler, and they have been, one of the doctors I work with, he refers me a lot of patients on methotrexate. I have done that without any problem. But again, I'm very religious about sterile technique.
Okay, thank you so much.
My question goes along with hers. Basically, like a not well-managed autoimmune disorder, like lupus, systemic lupus or something like that,
right.
Not on any type of therapy, but with injections. Yeah,
it's a very good point. I looked at the literature and I couldn't find really anything that's pointed to a major problem that arose from injecting a patient with lupus. Now, again, with regard to actually immunosuppressive agents, I haven't found that either. And I think it's because most people are just avoiding it, so because they're avoiding it, those complications never arose. The one thing that I did find that was interesting, there was an article about a young woman that had lupus, that had she had lupus profundus, which results in a loss of a lot of fat in the face, and the doctor ended up doing fat transfer, and she actually died on the table due to some kind, she ended up getting a pulmonary embolism, but they think it was because the cannula they were using was a sharp cannula and not a blunt one, and so it ended up shearing a vessel, and she got inadvertently bolused with a dose of fat into the artery. So it really didn't have anything to do per se with her lupus. Looking back, the use of blunt cannulas probably was safer. You know, you worry more in these autoimmune things about sort of the quality of the vasculature, because a lot of lupus patients are prone to like hypercoagulability. But I think that when, again, if you use good technique, you use you use, especially if you use like blunt cannulas, that it should be fine. But again, it depends on how comfortable and how brave you are. You know, do you want to, deal with that? But you should always talk with your patients. The other thing is, can it make their lupus worse? The answer is no. There's nothing really been, I don't know. There's not a lot published about it.
So you don't overall avoid patients that have autoimmune?
I don't, personally in my practice, but I don't get a lot of patients with autoimmune disease actually seeking those treatments anyway.
Okay, thank you.
Oh, in fact, I should say, I've treated multiple patients with, there's something called Parry-Romberg, and actually Dr. Goldberg was one of the first to show that. It's an autoimmune condition known as morphia, where you actually lose a lot of volume for your face. You can actually correct that by injecting these patients with a lot of filler. And if you look at the literature, there are a lot of people who are talking about correcting some of the wasting that's associated with autoimmune conditions with filler, and to very excellent results. So there has been a lot about that, and there's been no complications. So filler's actually been used to help a lot of those patients.
You mentioned in bee venom there's hyaluronidase.
Yes.
And so in the case of an occlusion, if we were to grab a non-bovine like Hylenex, could we still see a chance, if they are truly allergic to bee stings, of anaphylaxis?
Yes, and that's a very good point. You know, any patient with an allergy to bee venom, I think the concern that you should have is not with the filler, but with be able to reverse the effects if the patient doesn't like it. So my answer to you is yes. I don't know. Hyaluronidase, I think, is just a regular. If it's due to like some kind of protein that it's bound that's bovine related, then yes. Then if they have a known bovine allergy, then sure, maybe it's to that. But if it's actually to the hyaluronidase itself, which is a protein and an enzyme, you have to be really careful, or at least start with lower doses than the 20 units that most people start with. Oh, yes.
Could you speak to clients with MS and how you feel as far as injectability on them?
Filler or Botox, I'm sorry?
Both.
Filler, I have no problems. I actually have a patient with MS that I haven't had any problems injecting. She actually needed it. She's been on prednisone for years, and she actually had a lot of sort of, wasting. Prednisone can reduce a lot of the soft tissue that you have. It also can cause swelling. But I have no issues with that. As far as Botox, I would not. Because the reason is one of her major problems is diplopia, and all I need to do is aggravate that pre-existing condition to sort of get myself in trouble, so I wouldn't.
Yes, I wish you could speak to the neurotoxins, where some of the drugs, specifically calcium channel blockers and aspirin, which I see a lot,
yes.
You said there's decreased transmission. Is there a change in dosage? What do you
Well,
know?
again, I'm going to be honest, I just learned about that, the aspirin and Coumadin and the calcium channel blockers, and I inject, at least 6 patients per, I would say, 3 patients per session. And thinking back, I very often, and I'm guilty of it, I don't look at their medications. And I know a lot of my patients have high blood pressure, and in the community, they love calcium channel blockers. So I've never seen any problems with it. It is something that's on there, so I guess my recommendation would be you could continue to do that, but if you notice that they're having any problems, then it's it's something that you really have to look back on. Because you have to remember, overall, the dose of toxin that you're giving them is so low to produce a systemic effect. I think someone told me that the amount of Botox that you have to put in a person to approximate someone with true botulism is on an order of magnitude of like 10 to the 5, 10 to the 6, and we're only doing everything usually short of 100 units. So
right.
It's
I tell
very
all
hard.
my patients there's not enough Botox in the building to
Yes,
cause that type of reaction.
Yeah, exactly.
Not even enough in the building. But okay, so you're saying systemically, of course, a neurotoxin is not going in.
Right.
However, is the drug going to
Right. I haven't noticed any worse effect, or and again, spread is more of an issue of volume. So as Dr. Nestor was saying, but I wouldn't really be that concerned about it. I think it's too common, and I'm pretty sure I've injected a lot of patients on calcium channel blockers without even knowing they're on calcium channel blockers. All right, my next talk is the final talk for the day. It's fillers from a new, it says prospective, I changed it back to perspective because I was trying to think of a talk that I could give to you guys that isn't sort of this regurgitation of all the different fillers that are on the market, the majority of which you guys can't even use because they're approved in places like Europe and South America and not here. So I thought I would concentrate on the issue of how to use how to take filler and then inject it in a way when you have a patient that is cost conscious. How do you take filler and inject it in such a way that you're injecting it where the money counts? In other words, how can you inject filler in very strategically placed anatomic areas where you'll get the most bang for your buck for the patients without using, for example, 8 syringes of filler and then giving them this kind of blowfish look? So starting off, we want to talk about aging. You know, the great artists have already known that, the Italian artists, any artist I should say, that youth is associated with the ampleness of soft tissue. Sort of the full-faced youthful, full-faced cheek look is really associated with ideals of beauty and youth. Over time, this is what can happen, as the Dutch characterists can actually show, where you have loss of soft tissue, descent of fat pads, resorption of bone, strange headdresses. I mean, there's if you actually see the difference here, this person actually has significantly aged, and it's carried forward throughout history. So over time, and I think this is really influenced, especially now as opposed to the 80s, how we sort of perceive the youthful face and how we correct those deformities to restore youth without sort of making patients look artificial. So as you know, the overall shape of the young face is triangular with the apex of the triangle at the chin or the mentum. The contours of the young face result from the ampleness of deep fat, especially deep cheek fat. And this diffuse layer of fat hides the push and pull of muscles, and also stretches the skin in such a way where you get greater luminosity of the skin and gets rid of wrinkles. So as Dr. Nestor had talked about, there's 2 types of aging that occur over time. There's intrinsic and extrinsic. And when we're dealing with filler, we really are trying to combat the intrinsic factors of aging. Aging that is due to changes in anatomical structure such as bony resorption, heredity, hormonal changes, and biochemical changes. These are changes we can't correct. As dermatologists, we can stave off extrinsic aging by using sunblock, antioxidant agents, as Dr. Nestor had talked about, not smoking, but we can't really stave off the intrinsic hereditary types of aging or staving off gravity. So the shape of the aging face, as you can tell, with age you get fat loss and bony resorption. The roundness of the forehead and the cheek is lost. You get flattening and angulation of the tissues. The temples and the lateral third of the face become extremely hollow. Due to a bony resorption, you get irregularity of the anterior jawline, especially in the labiomental sulcus, and you get excess fat accumulation in the submental area or the neck area, which pulls down and accentuates the irregularity of the jaw. So here is, it's not the same patient, but just sort of, again, differing views of youth. You have the full, ample looking face of youth, and as you get older, unfortunately, bony resorption and loss of soft tissues. So knowing how the face ages anatomically with respect to bony resorption and soft tissue loss, particularly with regard to fat, will allow you to rejuvenate the face anatomically. So that what you can actually do is inject filler where it needs to be injected. If you understand how the face ages, you will know where to put that filler and where to put that filler with sort of a purpose rather than indiscriminately filling your patient with like 9 syringes of filler. You might be able to do 2 syringes of filler just by injecting in the areas where the patients are most prone to aging. And that's where most of the literature in the recent years has been sort of focusing on. Here you can see this patient. What's happening is she's had flattening of her malar prominence, particularly due to bony resorption, and the deep cheek fat and the deep nasolabial fat, known as rhistospace, has been sort of, those fat cells have been shrinking because they're very small fat cells. Restoring it with fat transfer or filler, as you can see, restores the natural contour of youth and actually makes the patient more in line, gives her a younger sort of more youthful look, but without making her look overfilled. So we have a large armamentarium of fillers available to us. And each of these fillers, as many of you know, and I don't have to sort of repeat, have their value in different levels of the dermis. You have some fillers which are very useful in the superficial dermal area, such as the old Cosmoderm or Bellatero. The mid-dermal fillers, such as Restylane, Juvederm Ultra. And then you have the subcutaneous fillers, things such as polylactic acid, the new hyaluronic acids such as Restylane Lift or Voluma. Those are the fillers that really are injected deep. Now, some people, and I heard this at a previous conference, have said that, well, as soon as you inject the filler, you're already in the subcutaneous space. Well, not necessarily. I always tell my residents when I'm training them, there are ways to physically see what level you're in the dermis are when you're injecting filler. So, if you're in the superficial dermis and you're using something like Cosmoderm or fine lines, if the filler, you can see the needle transparent through the skin and it comes out the pores, you know you're in the superficial dermis. If you're in the mid-dermis, typically you get a wheal. You don't see the needle necessarily, but you get actually a wheal, then you know you're in the dermis. And anything in the deep dermis or the subcutaneous, it actually tumesces. You don't get a wheal, but you don't get that peau d'orange kind of, wrinkled orange texture look. It actually tumesces very smoothly. So that's a way of knowing how deep you need to be. Now, once you know how deep you need to be, there's a whole variety of fillers that you can use here, and this is a figure that I just sort of mentioned before, where you can take advantage of their varying properties, so you know where not to inject them, but you can actually layer filler one on top of the other, so you can correct different problems at different levels of the skin and dermis. Now, this is an excellent article on the history of fillers. I could go over every filler, but I'm not going to do that. But there's such a wide armamentarium of fillers that are available to us right now that enable us to correct both the deep portions and the superficial portions of intrinsic aging. So, calcium hydroxyapatite fillers, okay, have the best. They tend not to spread and they tend to stay in one area. As such, they have great lifting capacity, okay? Then you have the non-stabilized, non-cross-linked hyaluronic acids, and then the cross-linked hyaluronic acids. They also tend to stay, but they tend to spread a little bit more than something like calcium hydroxyapatite. And then there's the very fluid filler, Bellatero, cohesive polydensified matrix fillers, which what they do is that they actually go in between the collagen fibers. They're very fluid. They're very good for superficial filling, but they don't have great lifting capacity. So you've often heard, there's been a lot of talk about this at a lot of the conferences, about the G' of fillers. The G' of a filler is basically its lifting capacity. So when you want deep volume and you really need a lot of lifting capacity, we tend to use the fillers on the left, such as the calcium hydroxyapatites or these type fillers, while when we're trying to fill very superficial lines, we tend to use these fillers. And this is a sort of an inverse sort of look at the fillers in terms of its fluidity. More fluid fillers, again, when you inject the filler, they tend to go and they spread out very, very, very quickly. They're very good for superficial injection because they spread out, you don't get the Tyndall effect, and you can massage them and they spread out. But it's very good for superficial lines, particularly along the crow's feet and around the mouth. So having this great armamentarium of fillers allows us to address some of the whole issue of intrinsic aging. Now, the arrows shown in this diagram actually show where in the face most villus aging takes place. And as you can see, you have aging along the medial upper orbit, the lateral inferior orbit, a lot of bony resorption that takes place in the maxilla, particularly near the piriform fossa, the medial maxilla, and along the chin, particularly right here, just along at the juncture of the mandible and the mentum, where you get that sort of depressed look that you get in the labiomental sulcus. So because of that aging, you lose this bony platform that actually supports soft tissue. So then what ends up happening is it's like an avalanche effect. It sort of encourages all the soft tissues to fall. So as you can see here, due to all this bony resorption that's taking place, all the soft tissue starts falling and all the different fat pads start separating from one another, producing this kind of double trio trough look, producing the accentuated nasolabial fold separating from the malar cheek fat. This is producing the hollows around the chin. So correcting knowing where these processes are taking place, if you actually inject into those places, actually gives you sort of a starting point when you're revolumizing someone from the point of view of rejuvenation. So here, this is a great article by Rod Rohrich and Joel Pessa, who have done a lot of research on this, showing about where all the major fat pads are. And a lot of the fat pad research happened in the past 2 to 3 years, which Dr. Nestor had already mentioned. But what's really been happening in the past, I would say, year and a half, was an understanding that there's 2 types of fat pads. There's the superficial and the deep facial fat pads. So the superficial fat pads are shown here, and then there's the deep ones. The deep ones are the ones you really need to address first, because by injecting into those fat pads, you will probably get more revolumization quicker with a smaller amount of product than injecting in the superficial fat pads. Sometimes you can even make, if you just inject superficially, particularly in the nasolabial fold, all you've done is increase the weight of that superficial nasolabial fold and made the angle here worse. The nasolabial deformity worse. What you actually have to do is inject deep down to periosteum, to the deep fat pads, because that will elevate the nasolabial fat pad in order to get rid of the deep grooves of the nasolabial fold. So this is a great article by Rod Rohrich, and it talks about the 4 most important fat pads. He talks about the deep medial cheek fat, the superficial nasolabial compartment, and what he specifically says is filling deep to this, not in it, but deep to that. So deep to the nasolabial fat pad is the deep nasolabial fat, and it's also known as Risto's space. So injecting into the deep medial cheek compartment, the deep nasolabial fat pad, as well as the lateral deep cheek fat, and the zygomatic fat pad, or the buccal fat pad, really can result in great results with filling. So if you can see here is a patient that Dr. Rohrich actually injected with. He actually used fat, though I know fat is not equivalent to filler. Some of the deeper fillers, like Voluma or Restylane Lift, if you just use a smaller amount of product into those areas, you can see how volumized these patients are. Now, some of you might say, oh, this looks like something else was done. In this particular paper, he filled first, and then he did a SMAS plication or a SMASectomy. So he did a type of facelift. However, for those of you out there who are specializing in non-invasives, what I do is I will not only inject then, because I don't want to do a facelift, I will recommend something along the lines of focused ultrasound energy to tighten the SMAS. But some of you might say, well, what's the order? I always do my focused ultrasound first, and then I fill deeply in those compartments, because my concern is if you use the ultrasound second, that you might melt the filler that you put in there. So, but as you can see here, knowing where to actually fill, and particularly in this case where what he emphasizes is filling in the deep cheek fat, which you can see right here, the apple of the cheek going right at the center, usually in mid-pupillary line, just before the nasolabial fold right here, will get you into the deep cheek fat. Then doing a second filling into the nasolabial area, but going deep onto the maxilla, that will also produce a considerable amount of filling. Also filling the lateral cheek fat, where you put a lot of your filler to produce that sort of egg-like look on the side. That will elevate the face and produce, results that are sort of superior to the old-time facelifts. So here's a woman, as you can see, who's been sort of aging over time. She's middle-aged, and what this diagram shows is the various areas where she could benefit from filler. So filling in her lateral cheek fat pads, her medial deep cheek fat pads, in Risto's space underneath the nasolabial fat pad, filling her eyebrows and her temples, also supplementing it with Botox, and also filling the chin. You can see how much she's improved without any kind of surgical procedure. Same thing here. You can see how much she's improved. Now, one thing some of you might say is the cheeks almost seem a little bit overfilled because the eye aperture seems to have decreased a lot. Yes, she's got an eye, and I sort of surveyed a bunch of my colleagues about this. Some people say, oh, she looks better. Some people say, oh, her eye aperture looks like it's decreased. I think in the majority of cases, though, most people would say she does have a more sort of youthful look. Now, what did she undergo? Temporal augmentation, augmentation of the lateral midface and cheek, augmentation of the chin and the lower third of the face. And also, she had augmentation of lips, maintaining a 1-to-2 ratio. So the upper lip, when you're filling lips in a Caucasian patient, it should be a ratio of 1-to-2 or 1/3 to 2/3. Because if you try to make the upper lip and lower lip equivalent in a Caucasian patient, that actually makes them look, it's sort of not natural looking and will actually give them that sort of duck appearance. Now here's a woman in her youth. When she came in with Dr. Rourke, where she was actually aging, and again, just following where he put the filler in the fat pads, in the temples, in the eyebrows, in the, in the medial cheek, the lateral cheek, deep to the nasolabial fold, also increasing sort of the chin projection. You can see, even though she's not completely restored to her youthful look, she looks sort of regenerated, but without looking fake or artificial. Now, one of the things that's also been coming out a lot in the literature, and this is from the most recent plastic surgery supplement, is how do you fill patients based on their various ethnicities. So as you can see here, this is a woman of African American descent. When you're addressing patients of color, particularly women of African descent, you tend to emphasize the mid-facial portion as opposed to the upper and lower third. In Caucasian patients, it's the upper third and the lower third that seem to make the most difference in a Caucasian woman. In an African American woman, it's the mid-face, because very often they don't have a lot of temporal atrophy. The difference is when you're doing the lips, unlike the 1/3 to 2/3 ratio that we were talking about with Caucasian patients, you actually do a 1-to-1 ratio. One thing that this article sort of emphasized, that you tend not to do white roll injections or the vermilion border in African American patients, because you will produce that more ducky look. Just filling the meat of the lips actually helps. And then increasing the actual chin projection also helps, because by increasing chin projection, you can see how much that's sort of reduced the amount of wrinkling that's take place in the lower third of the face. This is a Hispanic patient. Hispanic patients, the approach is very similar as with African American patients. Again, concentrating on the mid-face. Because there's a higher amount of pigment, they tend to have less extrinsic aging. They tend to have less temporal aging, and again, that's just genetic. However, concentrating on the mid-face, increasing chin projection can really sort of help when you're dealing with patients of Latino descent. Now, this is very interesting. This is a patient comparing a Caucasian woman with an Asian woman. And one of the things that this article sort of emphasizes, especially when you're understanding aging in various ethnicities, is where to put the filler. So as you can see, in patients of Caucasian descent, we tend to concentrate on the lateral malar fat pads, the deep fat on the more lateral aspects. However, with Asian patients, you tend to concentrate more medially, because as you can see, they tend to have more flattening of their medial maxilla, and it has to do with the way the medial maxilla is absorbed at a faster rate than in Caucasian patients. The other sort of strategy in dealing with Asian patients is a lot of Asian patients like to have decreased facial width, and one of the ways of sort of addressing that is actually Botoxing their masseters. You also want to increase facial height. How do you increase facial height? Well, you can increase temporal injections of filler, particularly in one of the hyaluronics or calcium hydroxyapatite. The other thing that you can do to increase vertical height is increase chin projection, particularly by concentrating on the mentum. Also, there is a lot of Asian patients like greater nasal bridge projection. But as Dr. Nestor said, when you start injecting in places like the nose and the glabella, you increase your risk of side effects, particularly blindness. That's why a lot of the demands, or what Asian patients sort of want as ideals of beauty, involve this area, just because of the way they age. And because of that, more of these complications are viewed in the Korean and Chinese literature, because people are trying to address something that's more specific to Asians rather than whites. That's why I think more of the complications, it's not only a matter of reporting, it's a matter of addressing the cosmetic concerns that are more specific to Asians as they age. So here is a woman that was injected by Dr. Rourke, again showing using a combination of filler and Botox. She's had temporal augmentation, lateral brow augmentation, augmentation of the medial cheek as opposed to the lateral cheek, nasal bridge projection. He's also Botoxed the sides in order to decrease facial width, and he's increased vertical height. Now, Men, this is another thing that's interesting. When you're looking at men, when men age, men tend to get what we call the reverse trapezoid. What happens is they get narrowing here and flaring of the jaw. You get much more prominent mandibles with thinning of the temporal areas. As to restore that youthful look, you reverse the trapezoid. You increase temporal projection and make this narrower. Now, as opposed to women, you don't want too much lateral projection, or that's very feminizing. The other thing that you should notice with men is that they tend to have a lot of brow ptosis. So injecting filler underneath the eye without using Botox can actually elevate. If you use Botox here, they might get that Jack Nicholson look, but actually using filler here can elevate that brow, because this is really due to loss of soft tissue under the brow. And again, also the medial maxilla as opposed to the lateral maxilla, that's where men tend to age more. So injecting more on the medial aspect to the deep cheek fat will help volumize. So here is a split face comparison of men and women. And again, as you can see, there's a difference. First of all, the ideal for men is to have a brow that's really pretty much parallel to the orbital rim. Women like an arch, which you can produce with both Botox and filler. Women tend to have more ample lateral deep cheek fat, whereas men tend to have more medial cheek fat. And then in terms of sort of overall shape, men like to have a strong chin. Women, you can increase projection, but you don't want to increase it so much that it's masculinizing. But again, the ideal of beauty in the woman is to sort of is to produce a heart-shaped face, whereas with the men, is to produce a line that goes straight down to preserve the squareness of the jaw. So here is a sort of a quick, this is not a video, but this is when you're rejuvenating the upper third of the face, is using something where you're actually injecting the temporal hollows. This is called the one-up, one-over technique, where you identify the temporoparietal fusion line. You go 1 centimeter up and 1 centimeter over. You go deep to bone, and the reason why you have to go deep to muscle and right on bone is you don't want to hit any arteries, and then you can inject into that space. Again, injecting under the eyebrows. I usually use a 25 gauge cannula. It's advanced parallel to the supraorbital rim, just above bone in an appropriate distance, assessed clinically. You inject the gel in a retrograde fashion after aspiration of the plunge. I like to use fillers that have a high G prime and don't spread a lot, because I don't want that filler migrating to the upper eyelid. And I always use a blunt cannula here because I don't want the patients to end up getting a large hematoma or a bruise. This is a patient that's been volumized. You can see here, one eyebrow was lifted here, then the second eyebrow, and this is around 6 months later. Again, we have already talked about filling of the mid-space, of the middle portion of the face. Again, I can't emphasize enough how it's so important to fill the deep cheek fat and the deep medial cheek fat, known as Risto space, because that's where you get most sort of bang for your buck, so to speak. This is a 6-point chin reshape technique. You'll see it in the slide handouts, but injecting in these 6 points, just using small aliquots of anywhere from 0.05 to 0.1 cc of filler, helps give you sort of the chin projection that you need in order to increase vertical height and to rejuvenate the lower third of the face. The ultimate goal is to restore these natural proportions where you have, now, trying to restore these proportions, this is fine for a Caucasian face, but you have to also remember that different ethnicities have sort of different proportions. So respecting that is very important. But, trying to accomplish this sort of regularity of feature is, while it is a goal, you should also remember to look at each individual patient and look at their asymmetries. So the final thing that I want to sort of concentrate on that's been really sort of new is the use of filler for the hands. As we talked about, calcium hydroxyapatite has been very useful for the hands. The key thing that I want to talk about is that really it's been sort of really well discussed now that the injection place that you want to go in is the subcutaneous loose areolar connective tissue just beneath the epidermis. You can approach it by lifting up the skin and inserting your needle straight in, or using a cannula. I like to use cannulas because I think it happens to be a little less painful. And the name of that area is called the dorsal superficial lamina. It's this space right here. You don't want to go anything below that, because if so, you'll get bruising, you can get pain, because the vessels tend to lie underneath. And here is an example of someone who was rejuvenated. Final thing that I want to talk about, this was one of the more recent things, again, the plastic supplement, is neck décolletage rejuvenation using filler. In this particular case, what they did is they injected in the subcutaneous fat superficial dermis area Sculptra. The dilution was 16 mLs, 1 vial, You put 16 mLs in there, and you inject it in a micro-droplet technique all throughout that area, and you do 1 vial every 3 months for 3 months, and you can see how improved. They also did some IPL here as well. So I'm going to, again, in terms of technique for injection, you can do serial puncture, linear threading. I use blunt cannula. The one thing that also is new, there is a new technique that people have been described called the tower technique, where you inject the bolus of your filler when you're going deep, and then as you're going out, you sort of relax. That way you get little sort of struts of filler, little pyramids of filler in there, and it gives you a very good lift, particularly with the high G prime filler like calcium hydroxyapatite. And I'm just going to end with a couple of pictures. So this is a woman who I just did with 3 sessions of polylactic acid. Again, injecting into the deep to the middle cheek fat, deep to the nasolabial fat, in the temples, and augmenting her chin. Also using Ulthera for focused ultrasound for the neck. Same thing with this woman, also using polylactic acid, 3 vials. You can see just by how much it looks almost like she had a mini lift without any kind of surgery, and using a focused ultrasound before the treatment, and then doing polylactic acid afterwards. This is a woman from 2004 and how she looked 2012. She was getting filler from a friend and injecting it herself into her lips. I think I showed this at a previous conference, so I also hyaluronidased her lips. And this is finally a woman that this woman is actually in her 80s when she had the procedure done. She had a previous facelift. She didn't want any other surgery. This was her in 2003, and this is her in 2011, using volumization of the face with Sculptra, Botox, and also using focused ultrasound on the neck. Thank you.
Thank you, Dr. Ciocon.